Welcome to the Emergency Severity Index Review. For those of you that are new to triage, this will prepare you to decide whether the patient is sick or not sick and who is safe to wait. For those who have been triaging for years, this is a good review on the changes that the ENA made in 2010. It's important that we are choosing the acuity for our patients correctly because it will reflect the staffing in our department and patient flow. For the duration of this session, I will refer to Emergency Severity Index as ESI. So let's begin. ESI is a tool that we use at triage to determine how sick the patient is, or if not, how long they can wait safely for a provider. It separates patients into 5 categories, 1 to 5, 1 being the most life-threatening. This tool also allows us to rapidly identify the small number of priority 1s and 2s and then sort the remaining who can wait. The word triage is derived from the French verb trier, which means to sort or choose. This system originated in the military to sort the soldiers who were wounded and those who could return back to the battlefield and the ones that were severely injured. It's great when we have open beds and anyone coming into the ER goes straight into the next available room. But when more than one patient comes in simultaneously, the key question is, are they dying and how long can they wait? And if they wait, how many resources will they require? The Emergency Nursing Association sets the standards for emergency practice. They state that the triage nurse will see each patient and determine their priority based on physical, developmental, and psychological needs, as well as factors influencing access to healthcare and patient flow through the emergency care system. The ENA also recommends that the triage nurse have a certain level of experience and qualifications, such as a diverse knowledge base, the ability to provide patient education, the ability to work under stress and collaborate with the interdisciplinary team members. They must also have the ability to make rapid, accurate decisions while understanding cultural and religious concerns that may occur with patients and their families. Ideally, the patient coming into the ER should be greeted by the nurse and triaged in 2 to 5 minutes. Of course, there are always exceptions to the rule, such as with pediatric patients and the elderly population, which may require more time. So what are the benefits of having a triage nurse? One of them is that they greet each patient, provide reassurance that they came to the right place for treatment, and one of the most useful actions a triage nurse can do is provide first aid. So whether it's an ice pack, dressing, protocol for pain management, or other quick interventions, it allows for the care to start right at triage. The RN can also provide emotional support. People in the ER come because they're in pain or something concerning is happening. Most times people come in with family or other support people, so the nurse has the opportunity to provide comfort and even teach right at triage, depending on the situation. You can see that the problem of overcrowding is a nationwide problem, with New England being at a 52% of overcrowding. One of the reasons being that it is a federal mandate that any patient that comes into the emergency room needs to see a provider, and second, that the primary care providers are in short supply. So this forces sick people to come to the emergency department because they have no other resource. So this is the 5-level triage system used in most emergency departments. The first level is the resuscitation level. So an ESI 1 patient needs some kind of life-saving measure and cannot wait for a provider. The provider needs to be present in the room as soon as the patient arrives for those life-saving measures. The second level is an emergency which patient is unstable, the nurse can go ahead and start some kind of treatment, but the provider needs to be in there within 10 minutes so that the patient doesn't continue to deteriorate, and then or potentially go into a ESI 1 and need life-saving measures. The third one is urgent, which means that the patient will need at least 2 or more resources, and we'll discuss resources a little bit later on. This patient is safe to wait, potentially in the waiting room, for a provider. The nurse can go ahead and start any kind of protocols that may be standing depending on the complaint of the patient. The next level is 4, which is a less urgent patient. This is more of, if you can think of your clinic type patient that may need just one resource. They're safe to wait for 60 minutes in the waiting room. Ideally, every patient that's in the waiting room should be reevaluated periodically, and any time the patient can be upgraded to a different acuity or downgraded every time they're reassessed. And then your 5th category is your non-urgent patient. This patient does not require any resources but does need still to see a provider. Perhaps it's something easy such as a medication refill. They essentially don't have any kind of complaints, but are there for some kind of follow-up or simple question that the provider needs to answer. So let's begin with assigning acuity. So you have a patient that comes into the emergency department, and with the initial encounter, you're going to notice the patient's general appearance, their work of breathing and circulation. So before vitals are taken, just by looking at the patient, you want to ask yourself the first question, and is this patient dying? If indeed this patient looks like they're in distress, they need life-saving measures, and this is something that comes with experience. The triage nurse ideally is one that has seen patients in a life-threatening situation. So this patient will be triaged as an ESI 1, taken straight into a room and have the provider go in there to initiate those life-saving measures. The patient will not stop at triage for vital signs. They will not have any other questions answered. Just based on their appearance alone, will become an ESI 1. And we'll go into some examples as to what an ESI 1 is considered. Okay, so let's look at some examples of what constitutes as an ESI 1 and patients needing life-saving measures. If the patient has an airway breathing problem that requires back valve ventilation, if the patient needs to be intubated, any kind of surgical airway, or they come in or need CPAP or BiPAP, they are an ESI 1. If they need some kind of life-saving measure where they need to be defibrillated or emergently cardioverted or have an external pacer placed, that is also an ESI 1. So the patient can essentially be alert and able to verbalize their discomfort, but they need these life-saving measures. They are an ESI 1. If the patient needs procedures such as a needle decompression, a pericardiocentesis, an open thoracotomy, or an insertion of an intra-os access in order to provide any medication that is a life-saving measure, that is also an ESI 1. If the patient is hemodynamically unstable where they need IV fluid resuscitation, they need blood transfusion administered, or any control of major bleeding, they are also an ESI 1. If the patient requires medications such as naloxone or Narcan to reverse their respiratory depression, they're an ESI 1. If they are hypoglycemic and unstable where they may be unresponsive or have any kind of altered mental status, that is a life-saving measure to give somebody an amp of D50 because the brain cannot function without glucose. So that would be considered a life-saving measure. A patient required dopamine for unstable blood pressure, atropine for a unstable heart rate below normal, or if they need adenocard or adenosine for a unstable SVT. This will all be an ESI 1 patient. This patient needs to be in the room immediately with a provider, as well as the nurse to provide life-saving measures. So notice on the non-life-saving side, these are things that can be initiated by the nurse. This is something that perhaps could be considered a treatment or diagnostic. So this does not have any kind of life-saving capability. So a patient just being placed in a nasal cannula or in a non-rebreather, it is not life-saving. Putting somebody on the cardiac monitor gives us a lot of information as to what's happening, but it is the actual act of putting a person on the cardiac monitor cannot save their life. Doing an EKG, lab work, ultrasound, focused abdominal scan for trauma, again, gives us information to help us diagnose, but does not have any life-saving capability. Any patient needing IV access or saline lock, although some of the stuff will happen simultaneously with your life-saving measure, it is not the only reason why a person will be assigned an ESI level of 1. Before 2010, the standard for ESI 1 was reserved for those cardiac arrest and respiratory arrest patients, but after the ENA made changes, they opened up that ESI to more type of patients that were requiring life-saving measures. The concept is that the provider needs to be in the room and initiating those life-saving measures, so patients that come in with an SpO2 less than 90, perhaps need definitive airway, should be considered an ESI 1. Critically injured trauma patients who are unresponsive will need life-saving measures. Any overdose with a respiratory rate of 6 or below, you would anticipate them needing Narcan, so they should be an ESI 1. A severe respiratory distress patient with agonal or gasping type respirations will need a definitive airway. Severe bradycardia may need an external pacer or atropine. A tachycardia may be unstable and hyperperfusion. Patient will need medication and perhaps fluid resuscitation. Patients that are hypotensive may also need medication to help with the perfusion. Trauma patients who require large amount of fluid resuscitation or blood products, any kind of controlled bleeding needs to be an ESI 1. If a patient comes in with complaint of chest pain and they're showing signs of hypoperfusion and appear pale and diaphoretic, have an unstable blood pressure, should be an ESI 1. A patient who is weak, dizzy with a heart rate of 30 will need an pacer or perhaps some atropine to help them with their heart rate. A patient with anaphylactic reaction can progress fairly quickly, so you want to stabilize this patient, perhaps establish a definitive airway before swelling gets worse, and get that epi on board as soon as possible. So that the respiratory distress doesn't progress. A baby that appears to be flaccid needs to be taken care of immediately, so they would be an ESI 1. A patient who is unresponsive with a strong odor of ETOH, you have to assume the worst. You cannot just assume that the patient's intoxicated. Perhaps there's something else going on that's life-threatening, such as hypoglycemia or a head injury. So you have to kind of get the patient in the room with the provider and initiate any life-saving measures. A patient that is hypoglycemic and needs dextrose will also be considered an ESI 1 because that life-saving measure cannot wait. Okay, so let's try an example. A 67-year-old male comes into the ER by car. He complains of severe abdominal pain. He says, "It feels like I'm ripping apart. The pain started about 20 minutes ago and is a 10 out of 10. He is hypertensive and takes diuretics. The patient is sitting in the wheelchair moaning in pain. His skin is cool and diaphoretic." So based on the general appearance of this patient, just by looking at him, you notice that he is in distress. Circulatory is an issue with his cool and diaphoretic skin. He is complaining of a ripping pain, which should alert you that perhaps this is an AAA rupture. So the patient needs to be an ESI 1 and brought in right away. Okay, so let's try another one. This is a 25-year-old female that comes in with complaint of, "The smoke was so bad, I just couldn't breathe." She has a hoarse voice and complains of sore throat and is coughing. You know she is working hard to breathe. She has history of asthma. So this patient should be an ESI 1. She has significant airway injury from the smoke and will need intubation. Okay, so we've gone over what constitutes as an ESI 1 patient. So now let's go into the next category, which is your ESI 2 patient. And this patient is unstable and should not wait more than 10 minutes. So you've answered the first question, is this patient dying? The answer is no. But the next question is, shouldn't wait in the waiting room, essentially. And if they shouldn't wait in the waiting room for either physical distress, any developmental or psychological need, then they need to be an ESI 2. So the patient needs to not stop at triage for vital signs. They can go straight into the next available room. The team of nurses can certainly start any type of treatment, whether it's their protocols to get blood work or put on the cardiac monitor, establish any, maybe start normal saline or nasal cannula, non-rebreather, such things, or just provide a safe environment if this is a psychological issue. So the provider ideally should be in the room within 10 minutes. The patient may be potentially worsening, so they should not wait more than 10 minutes so that the doctor can go ahead and start any kind of additional orders, whether it's imaging or medication, so that the patient
another way to think about it,
the triage nurse knows that this patient should not wait, so they make them a priority 2. So the idea is that this could be a high-risk situation. The patient may be confused. So if they're showing signs of inappropriate response to stimuli, they have a decrease in attention span and memory, if they're lethargic to the point where they're drowsy or they're sleepy more than usual, or just doesn't respond appropriately when stimulated, they should be a ESI 2. They're a high-risk patient and should really be going to the next available room. If the patient's disoriented, and this is new, the patient is unable to answer questions, simple questions as time, place, or person, then they should be an ESI 2. So examples of confusion, lethargy, and disoriented. Let's say this is a new onset confusion for an elderly patient or a baby whose mom says they're just not acting appropriately or sleepy all the time. If it's an adolescent that perhaps is confused or disoriented, we're going to assume that there's either a structural or chemically compromised brain injury, So they need to be seen within 10 minutes and definitely not go into the waiting room. Okay, so some examples of an ESI patient that cannot go back into the waiting room. A patient with active chest pain but otherwise stable, so they are not showing any signs of hypoperfusion. But if the patient comes in with complaint of chest pain, we need to get an EKG done right away and read to make sure that they're not having an MI or any other unstable, life-threatening cardiac issue. A patient that comes in with a needle stick, so somebody from the hospital, from another floor, got stuck by a patient dirty needle, they need to be an ESI 2 and registered and seen by the provider within 10 minutes of arrival. The last thing we want is this patient to think that getting a needle stick is not a big deal, and we put them into the waiting room, because that's kind of what the message implies, is that we're going to send you into the waiting room because this isn't a a high risk situation, when indeed it's the opposite. This is a very high risk situation. We want to not only reassure the patient that we're going to do everything that we can to take care of them, but we want to go ahead and get our protocol for needle stick initiated and start any kind of treatment if it's warranted. A patient that comes in with signs of stroke but not unresponsive, which would make them a category 1. So a patient that is exhibiting weakness or facial droop, they need to be seen by a provider and have that NIH stroke scale within 10 minutes of arrival. So ideally the provider needs to get in there and start their assessment, get that NIH stroke scale, and bring the patient to CAT scan for a head CT. The patient that is complaining of abdominal pain and can potentially be an ectopic pregnancy, otherwise hemodynamically stable, should be an ESI 2. They need to have a provider evaluate them. The patient needs to have vital signs just to make sure that there's no rupture or that they're not going to worsen in the waiting room. A patient that's on chemo with a fever is immunosuppressed, and they really should not go into the waiting room for the mere fact that they will be exposed to everybody out there and can get much sicker. A patient who is showing signs or has verbalized that they are suicidal or homicidal are not safe to go into the waiting room. They need to be put into a room where they can be safe. And perhaps if they are needing medication, that needs to be done as soon as possible. So abdominal pain is a common complaint in the ER. So the triage nurse needs to take a step back and ask what makes this abdominal pain a high-risk situation. And there's a couple of factors. Pain rating may be a factor, or once you do vital signs, something is unstable that would make it a high-risk situation. We also have to consider the elderly population as a high risk, because if they're having abdominal pain, they have a high potential of perhaps a bowel obstruction, a GI bleed, or other complications that can be significant for a higher morbidity and mortality when compared to your younger patients. So another a key kind of word that may make this a high risk, if the patient is complaining of a ripping kind of abdominal pain, you want to consider perhaps this could be an abdominal aortic aneurysm, and they should be in a high risk and brought in for evaluation. Otherwise, perhaps the patient is vomiting blood or complaining of blood in the stool, then they should definitely kind of be considered along with their vital signs that this is not a patient that is stable to wait in the waiting room. The next common problem or complaint that the patient in the ER has is chest pain. So not every chest pain is an ESI 2, but we do need to consider that sometimes it's difficult to determine if they're having a acute coronary syndrome at triage. So if the patient is having complaints of epigastric discomfort, with or without symptoms, they usually will need an EKG to determine whether they're having an acute coronary syndrome and be made an ESI 2. Otherwise, the triage nurse has to kind of take a step back and see, okay, is this patient otherwise healthy, has chest pain but cough and fever? The potential for acute coronary syndrome is low, so they don't necessarily need to be made an ESI 2. Every patient is individual, so the triage nurse kind of has to draw their knowledge of acute coronary syndrome. Also, think of women and their kind of presentation and unspecific characteristics of heart disease. So perhaps you have a female in their 50s that has epigastric pain and fatigue. This is a high risk situation, and they should be in ESI 2. Another example of the high-risk situation is those nosebleed patients that are on Coumadin. They have a potential for losing a large amount of blood if not controlled. They also have a potential for their airway to be compromised because of the amount of blood. If this patient's having a nosebleed and is hypertensive, they are also a high-risk situation because the increase in blood pressure is making the bleeding worse. If the patient also has history of recent cocaine use, they should be in ESI 2 because they are considered a high-risk patient. Patients with complaint of difficulty swallowing, perhaps this is an epiglottitis, they have a potential for obstruction. So if the patient says, I'm having difficulty swallowing or it hurts to swallow, don't be afraid to kind of look into their mouth and see what's going on in their throat. You want to make them an ESI 2 and get them to be seen. Perhaps they will need to have an airway established. If the patient has had any kind of inhalation injuries, they should be considered high risk because, again, they may have potential for their airway to be compromised and they may need a definitive airway. If the patient has an environmental or an inhalation injury that indeed is showing signs of airway distress, then this patient should be in ESI 1 and have a definitive airway established right away. If the patient has a facial fracture, this is a high-risk situation because they can have an airway compromise and swelling can get worse. So if they are not having any airway compromise, they should still be in ESI 2 just because of the high risk. If they are having any signs of difficulty breathing or compromise, then they should be in ESI 1. Other general medical complaints that should be considered a high risk is a patient that you are suspecting may be in DKA, perhaps hypo or hyperglycemic, or if they meet sepsis criteria, then they should be a ESI 2. Some more high-risk situations. Let's say a patient comes in complaining of fainting or passing out or feeling like they had a temporary loss of consciousness. They should be a high-risk situation, rule out syncope patient and brought into a room for evaluation. A patient that perhaps is sent in from their doctor's office, or they were called in because they had lab work and they had hyperkalemia, they should also be brought into a room and placed on the monitor and have repeated blood work quickly. They should not go into the waiting room. A patient with weakness that happens to be a chronic renal failure patient should also be brought into the next available room because they have a high risk of having electrolyte imbalances. The oncology patient, as I mentioned earlier, is immunocompromised, so they should not be in the waiting room. A male that complains of testicular pain, this patient needs to be evaluated to make sure that they don't have a testicular torsion that could have long-term effects. They need a urology consult and treatment as soon as possible to avoid worsening or any tissue destruction if they are having a testicular torsion. A patient that is brought in from dialysis because they became hypotensive or hypertensive or complain of dizziness or weakness, any kind of interruption of that treatment needs to be evaluated because they are potentially still fluid overloaded and they have electrolyte imbalances. Any urinary obstruction should also be seen fairly quickly. Within 10 minutes, the patient can be very uncomfortable with that urinary obstruction and can become very unstable. The progression can worsen. They can go into a polynephritis and have other complications, so they should be seen within 10 minutes. A patient that has mental health issues, such as saying that they're suicidal or homicidal or having any kind of psychotic event, they're violent or an elopement risk with potential for harming self or others, needs to be an ESI 2 and placed in a safe room. A patient that's intoxicated is not a reliable source, so they can't tell you with 100% certainty that they didn't in fact hit their head or that they fell. So there's potential for them to have confusion or slurred speech because of a head injury and not just because they're intoxicated. A patient that complains of that worst headache of their life needs to be a high-risk ESI patient. Any change in mental status, high blood pressure, lethargy, fever or rash, they should also be an ESI 2 because of the potential of having a medical problem that can worsen in the waiting room. Moving on to more high-risk situations, a patient with an ocular injury can have severe debilitating effects from such injuries like a chemical splash. So although this is not a life-threatening situation, it is high risk because of the potential for disability. An orthopedic high-risk situation is suspicion of a compartment syndrome. So the patient with a cast is complaining of pain that's increasing, paresthesia, if the skin appears to be pale, there's decreased CMS, paralysis, pulselessness. then this patient is at high risk for compartment syndrome and injury to the extremity and potentially could need surgery. A pediatric patient that has had a seizure, appears to be dehydrated and DKA, a child that you may suspect is child abuse, needs to be placed in a safe place. Pediatric burns needs to be an ESI 2 or a 1, depending on the severity of their injuries, if they potentially will need large amounts of fluid resuscitation. A pediatric with head injury, especially if they're withdrawing or just not acting like themselves, needs to be an ESI 2. Pediatric with any type of vitamin or iron ingestion needs to be treated right away. A baby that's under 28 days old with a fever needs to be an ESI 2 and made high-risk patient. A patient with a recent transplant of any organ or is on the list cannot wait in the waiting room, needs to be placed in a room and treatment started. Any respiratory issues such as an asthma exacerbation, potential for PE, pleural effusion, a pneumothorax, a foreign body aspiration, any type of a toxic inhalation, or short of breath with chest pain is an ESI 2, although they don't need any really life-saving measures. Initially, the potential is there, so they need to have a provider see them fairly quickly. Patients with known or suspected overdose, whether they admit to what they've taken or maybe they're not sure, needs to be an ESI 2. We need to get a good story and determine what they've taken and how much. We also need to determine whether this was accidental or perhaps suicidal ideation, which would definitely make them a high-risk situation. Other patients, such as trauma patients, even though they don't have any obvious injuries, we need to make them an ESI 2 based on their mechanism of injury. So if the acceleration-deceleration force is significant, we need to consider that and get them evaluated to make sure that they don't have any injuries that we're missing. Motor vehicle and motorcycle crashes, falls, any gunshot stab wounds that would be blunt or penetrating trauma need to be assessed fairly quickly. A patient that comes in with a wound injury, if they need some kind of controlling in the bleeding, so if it's something like an arterial bleed or a partial amputation, they should be made an ESI 2 and treated for their injury so that they don't continue to bleed out and have circulatory compromise. So let's look at a special population, which is our pregnant females. Any patient that comes in and says that they are pregnant, regardless of the complaint, we should give CBC a call and just let them know, hey, I have this patient, they're coming in for such and such complaint, and they will determine whether they want to see the patient or not. So let's say that this patient is a above 20-week trauma patient and they come in through the front door. So we need to make sure that they are stabilized, and then once the patient is determined that they don't have any life-threatening injuries, they can then go to CBC, or the CBC nurse can come to the ED to check any fetal heart rate or have the obstetrician take a look at the patient. So even if it's not a pregnancy complaint, whether it's the patient coming in for congestion or chest pain, any kind of complaint, our policy is that we do give the nurse at triage gives the CBC nurse a call and just run it by them and say, hey, I have this patient. Do you want to see them after we do our part? If it is a patient that is above 20 weeks with any kind of trauma, we would stabilize and then ship to a facility that can take care of a trauma patient, a pregnant trauma patient. Okay, so let's say that you have done your across the room evaluation, the patient's general appearance, work of breathing and circulation look like it's not life-threatening. They indeed can wait for a provider. You can go ahead and bring them into your triage room, start doing vital signs. If while you're doing vital signs you notice that there is danger zone vital signs, or something is out of normal range, you can change your ESI and upgrade them to an ESI 2 based on your abnormal vital signs. So you can go ahead and get the patient into the next available room and let the provider know that they need to get in there within 10 minutes, and the nurses can start any kind of treatment. So some of your danger zone vital signs that you'll want to consider upgrading to an ESI 2 is if your pediatric patient, 1 to 28 days of age, has a temperature of above 100.4 Fahrenheit. If your 1 to 3 month old baby has a temperature above 100.4, you also want to consider ESI 2. A 3-month-old to a 3-year-old can be safely made an ESI 3 if they have a fever, because one of the things that you could do at triage is offer Tylenol or Motrin, depending on whether the patient got anything at home. If while you're getting the history, the parents say that they have incomplete immunizations, or maybe there's no obvious source of fever, then this is a high-risk situation and the patient should be in ESI 2 and brought back to see a provider. I mentioned severe pain as one of the criteria for ESI 2. So let's look more into pain. Pain is subjective, so it's whatever the patient tells you it is. So if they're telling you that it's a 10 out of 10 pain, that's what you document. But pain is just one part of your assessment or one part of the information that you're gathering. You want to document their appearance. So if the patient is otherwise sitting comfortably, able to talk in normal, without distress, they're sitting laughing or munching on potato chips, then document that. So you're basically stating why you are considering putting this patient in the waiting room, and why they're not in severe pain. The other part of pain is that if you can implement any kind of comfort measure at triage and document that you did that, and then state that that is the reason why you're safely putting the patient in the waiting room, then you don't have to make that patient an ESI 2. So this is something that you kind of have to recall on previous experiences. If it's a patient who is having renal colic, there's very little you can do at triage because this patient essentially needs an IV placed, they need analgesia, so you would make this an ESI 2 level. You want to ask yourself, would you use your last bed for this patient? Is the pain severe enough that you would give this patient the last bed? Otherwise, is there something that you could do at triage to help them with their pain? Perhaps you can offer them an ice pack. Perhaps you can position their extremity to a point where they feel a little bit more comfortable. Perhaps you can give some Tylenol or Motrin at triage. So you can implement things that address their pain, even if it's above a 7. But you are also documenting why they're able to wait in the waiting room, and basically you're not using your last bed for this patient. Okay, so this is the next scenario. EMS arrives with 80-year-old male with a self-inflicted laceration to his neck. The bleeding is controlled, and he's tearful and tells you that his wife died last week. Because of the type of injury to the neck, this patient has a potential for airway compromise. Although the bleeding is controlled, he does tell you that he is suicidal, so he needs to be an ESI 2. So in order to determine whether the patient is an ESI 3 versus 4 versus 5, we want to count how many resources is it going to take for this patient to have a disposition made. So this is where nursing experience is very important, because they will recall, what is typically done for a patient who presents with this type of complaint. So for example, let's say a patient comes in with abdominal pain. You have established that they are not having a life-threatening event, that they are not high risk. So what are we going to do typically for this patient? Let's say it's a 20-year-old male with complaint of abdominal pain. Perhaps they'll need a hep block with IV medication for pain and some lab work. Okay, that is considered 2 resources, so you would make that patient an ESI 3. Lab work, regardless of how many things go to the lab, whether it's a combination of urine and blood, that counts as 1 resource. Images such as x-rays, EKGs, CTs, MRIs, ultrasound, that is all bunched into 1 resource. IV fluids is another one. IV and IM or nebulized medications is 1 resource. So excluding a tetanus shot in the IM, a tetanus shot is not considered a resource. If the patient needs a specialty consult, such as they need neurology to see them or cardiovascular consult, that is a resource. If the patient will need a simple procedure such as a lac repair or Foley cath, that is considered 1 resource. So if the patient comes in with a urinary obstruction and you're going to put in an IV for fluids, and you're going to put in a Foley catheter typically, that will constitute as an ESI 2 because it's 2 resources. So 2 or more is considered a category 3. If the patient, you anticipate that they will only need 1 item from the not resources list, so if the patient just needs PO medication or a tetanus shot, or we need a callback from their PMD, those are not considered resources, and they would not be made an ESI 3. So 1 resource is an ESI 4. So if the patient is only going to need lab work, then they'll be an ESI 4. If the patient will have no resources, they have no complaints, you anticipate none of your resources being used, then they will be an ESI 5 patient. So notice that obtaining a history and physical is not considered a resource. Any point of care testing, some facilities do pregnancy tests in the ER or AccuChecks.
that is not considered a resource. A HEP block by itself is not considered a resource. PO medications, a tetanus shot, even though it's an IM, is not considered a resource. A simple phone call to a PCP is also not considered. Any simple wound care, so if a patient just needs a dressing, they would not be considered as a resource, or crutch education or splint, that is also not considered a resource. So patients, again, that need 2 or more of your resources will be an ESI 3. If they only require 1 resource, then they are an ESI 4. And if they don't require any resources, they are considered an ESI 5 patient. The next scenario is a 25-year-old female that comes in with complaint of abdominal pain for 4 days. She's been spotting, denies nausea, vomiting, or diarrhea, and has no urinary symptoms. Her last menstrual period was 7 weeks ago. She has a history of an ectopic pregnancy, and her vital signs are a temp of 98, a heart rate of 66, respirations at 14, and a blood pressure of 106/70. So based on her complaints, she's going to need at least 2 resources. She'll definitely going to need confirmation whether she's pregnant or not. She may need an ultrasound, blood work. She's hemodynamically stable, so this patient can be an ESI 3 and can safely wait for the next available bed. So a few take-home tips. You want to triage based on the presentation of the patient to the ED. So if they came in by EMS and they were, say, unresponsive or had some life-threatening situation that EMS addressed, and now at arrival the patient is much more stable, you want to base your ESI based on the presentation of the patient in the ED. Now you do want to consider the backstory and what happened pre-hospital, because that can contribute to whether your patient is a high-risk situation, but you want to remember that you are basing your ESI on how the patient appears when they come to the ED. Thank you for taking the time to review ESI. If you would like to get credit for participating in this review, simply fill out the questions and email them back to me at jmunoz@griffinhealth.org. Thanks.